you have in the palms of your hand. Some of you do not, but this is present in virtually all of us, and you can see it sort of extends anteriorly to sort of enshroud or encapsulate the tendons, at least anteriorly. Now, with respect to the muscles of the foot, we've already differentiated intrinsic and extrinsic muscles. In this slide, there are listed the intrinsic muscles of the foot, and these are in several categories. You have the interosseous, which we'll see in just a moment, that are important for spreading the toes. The flexor digiti minimi, we're going to talk about what the digiti minimi is. The flexor digiti minimi brevis, only the brevis is intrinsic. The flexor hallucis brevis, that's also the intrinsic one. So in all three of these cases, the flexor digitorum hallucis and digiti minimi, it's the brevis that is intrinsic. And then there's a quadratus plantae, which is sort of a intermediate muscle. It's in between the ligaments of the foot and the outer layer of muscle. It's sort of in a mid position. It's unusual in the foot because there's nothing like it in the hand. It's sort of a stabilizing intrinsic muscle of the foot. And then, of course, you understand what we mean by abductors. The abductor is going to move the digiti, the little toe out. Abductor hallucis is going to move the large toe out. And then the lumbricals, we'll look at a picture of these. The lumbrical just means worm. So these are worm-like little muscles that extend up through both your toes and your fingers. And in the human foot, they really don't have a lot of function because we don't, unless you have a different lifestyle than me, we don't do much with your toes, my guess is. So we're looking at the intrinsic muscles of the foot, or at least some of these, and I'm going to simplify this dramatically. The traditional organization of these intrinsic muscles is to present them in 4 layers, from most superficial to most to deepest. The first layer, we're just going to summarize to say, consists of this large flexor digitorum. That's the flexor. Remember, all of these flexors that are intrinsic are brevis. They're all going to be brevis. So that's the largest of the 3. And then you have the 2 abductors, the abductor for the little toe and the abductor for the big toe. So that's going to be in the most superficial layer. The second layer, then just sort of underlying that, are those wormy lumbricals that we have argued really don't contribute much to your life. They're very important in your hand, but arguably less so in the foot. And then deep to those are going to be not the abductors, but the adductors. So we have the adductor for the large toe, and we also have the flexor of the large toe in the 3rd layer. And then finally, deepest or most integral or intimately associated with the bones are these interosseous, and they are fairly important in both the hand and the feet because, as we pointed out, they enable you to adduct and abduct the digits to the extent that you're able to do that. If you're like me, that you probably don't want to do that very much because it inevitably ends up in cramping of the foot. In a surface anatomical representation, such as you see on the left, you should be able to identify the tibialis anterior tendon there. So continuing down, you should be able to recognize the extensor digitorum, sort of running along that plane as well. What else is there in here we should recognize? Oh, the extensor, the big toe extensor, extensor hallucis brevis. I guess that's it. So in our previous illustration of the relationship between the distal fibula and tibia, we looked at the complexity of the talocrural joint. The talocrural joint, that's the proper term for the ankle joint. And you can see it's sort of it has both a horizontal and vertical aspect, both limiting or regulating movement of the ankle. Now, you can sort of see you can sort of see this joint along several planes, and it's a complex joint. It's relatively complex to the extent that it involves multiple bones. We're just going to call it, we're just going to really describe this. I think, let me try to rephrase this. We're going to learn the names of the bones. We've already done that. And we, of course, we know the relationship here. I will ask you in a moment to be familiar with the terms used to describe the distal joints. But frankly, I find that some of the terms, this is my personal opinion, I'm editorializing here, but that's what they pay me to do. Some of these joints back in here just have silly names, so we won't worry about that. But I do want you to be sure that you can name the bones, and obviously, if there's an articulatory surface between those bones, you should be able to make a logical inference about what that surface would be. So to that end, let's look a little bit at some of the stabilizing ligaments of this ankle joint. And we generally differentiate the lateral ligament and the medial ligament. Now, as was the case in our discussion of the bones, or the complex bones that make up the ankle joint, some of the hindfoot or the midfoot joints here, notice that in the case of the lateral ligament, we'll look at the medial ligament in just a moment, usually there are 3 or 4 of these. And if you look at the terms here, if you look at the names of these ligaments, talofibular, calcaneofibular, and anterior and posterior talofibular. So obviously the implication is this is a ligament that binds the talus to the fibula. And we're looking at these 3 ligaments right here. So while I do not require that you memorize these ligaments, I would expect that you be able to identify the bones to which they are attached. Now this is again the lateral ligament. You can sort of see those same ligaments right there. And again, the key word is fibula. They're all going to attach to the fibula to one degree or another.
On the lateral side, there are 2 important ligaments. The calcaneofibular ligament, which goes from the lateral malleolus to the side of the calcaneus, and this strong ligament, the interosseous talocalcaneal ligament, which goes from here on the calcaneus to here on the talus. To see that ligament better, we'll remove the talus. The interosseous talocalcaneal ligament lies between the subtalar joint and the TCN joint.
And you see the incredible complexity of the bones in that region.
On the lateral side,
on the medial side, we have a similar arrangement, except the ligaments are arranged a little bit differently, but of course we're not going to have the fibula to deal with here. Notice all of these ligaments have the word tibia in there. Tibiotalar, tibionavicular, and tibiocalcaneal. So these together constitute the medial ligament, and because of its triangular shape, it's also called the deltoid ligament. As these ligaments become weak with age or athletic stress, sometimes the stability of the ankle is compromised. You see them sort of clustered there.
Several strong ligaments hold the malleoli, the talus, the calcaneus, and the navicular bone together. On the medial side, which we'll see first, there's one extensive ligament to look at, the deltoid ligament. We've seen part of it already. Now here's the whole of the deltoid ligament. This is the part we saw before, going from the medial malleolus to the talus. In addition, parts of the deltoid ligament fan out below onto the sustentacular talus or the calcaneus
ankle joint,
and in front onto the navicular bone, so that the deltoid ligament holds all 4 of these bones together. Several.
I have more trouble. Well, I think I'm going to give up. But I just wanted you to see as we talk about these ligaments, again, the remarkable articulatory surface, and it's those ligaments that keep everything in place as this very large exposed surface is moving to and fro in that very limited capsular space. So I think we've already talked about the terms used to describe movement of the ankle joint. Like we've already talked about dorsiflexion, plantarflexion. We've talked about inversion, eversion. You get some idea now of how those types of movements and motions are restrained by the relevant bones and ligaments. The blood supply to the ankle joint chiefly by branches of the tibial arteries, and then the innervation to this region also from the tibial and the tibular nerve. Now, as I've indicated, I think the terms used to describe some of these joints are unnecessarily complex and probably not entirely necessary for our discussion. So what I'm going to ask you to do, let's look at this slide. And I want to make sure you understand the joints that you need to be able to identify. And why don't we work from distal to proximal? So we'll work in this direction. So notice these red joints up here are called interphalangeal. So be able to recognize the interphalangeal joints. Then the joint between the phalanges and the metatarsals, logically, is called the metatarsophalangeal joint. Metatarsophalangeal. You have the intertarsals here. And then the tarsometatarsals, or these little blue lines that you see there. And that's it. I'm not going to, if you know the names of the bones, I think you can probably figure out the interior. But you should know the distal, in part because these are most vulnerable and most likely to be damaged in some type of traumatic injury. So we've looked at the medial and the lateral ligaments. We've looked at the plantar aponeurosis. So we're very much deep to the intrinsic muscles. We're deep to the plantar fascia. What we're looking at now are these ligaments of the foot. And once again, I'm going to try to summarize some of the general themes we'll be discussing in the remaining slide. You're probably aware of the controversy that was engendered when some of the amputee patients wanted to perform in the Olympics. And so you've probably seen the Blade Runner, for example. Of course, he came to an unfortunate set of circumstances. But you remember the controversy over whether an individual with one of those specialized orthopedic limbs has an advantage over an individual who's running normally naturally with the normal apparatus. And if you're familiar with how that debate turned out, there were quite a few studies performed. If not, what would you guess? Have you seen what I'm talking about? Basically, it looks like a little, the lower limb is like a little scythe, and it has a very flexible fiberglass ending, which can accommodate a special type of shoe. And of course, it had very springy. So it's in theory, like a kangaroo. Just bounce up and down all day like you're on a trampoline. So that being the case, and you look at the system of muscles and joints and the ligaments that we'll be talking about or continuing to talk about here, who would have the advantage, do you think? Would there be any difference? Of course, it's hard to know because none of us have really been on these prostheses. Yeah, most of the research that was done suggests there's a marginal advantage to a natural foot. And so my point here, as we talk about some of these remaining structures, it's important to understand this is a very dynamic pre-tension, pre-torque system. As you know, a normal human foot has several arches. You have a longitudinal arch and a transverse arch. you have all of these ligaments we're talking about, and in addition, you have the intrinsic muscles which act to contract, to facilitate your movement. So my point is, as we continue our discussion of all of these structures, these all contribute to that dynamism, that tension, that ability of the foot and the ankle to respond in a spring-like fashion. In many respects, analogous to what the blade-like prostheses would do. So what we're looking at here, you can see some of these plantar ligaments, some of these ligaments on the underside of the foot. This is the long plantar ligament. Just deep to that is the short plantar ligament, and you have, I think, a better illustration of it here. This is the short plantar ligament there. And then over here, this is sometimes called the spring ligament. So those three ligaments really are critical to the dynamism of the plantar foot. Typically, when all of these ligaments, bones, and intrinsic muscles are performing properly, most of our weight then is allocated either to the heel of the foot or the ball of the foot. And this region in between should be contributing to the flexibility, which also gives us that dynamic spring we were talking about a moment ago. Again, this would be the longitudinal arch along that plane. And so most of us, there's a depression, there's a concavity there. And then, again, in the normal foot, there is a transverse arch as well. All of which are a little springy. And so oftentimes when we talk about the arches of the foot and whether they're present or the extent to which they're present, you notice, for example, most modern footwear lacks any sort of arch support. I guess the idea there is that you have to go out and buy the arches, and that makes everybody happy who's selling shoes and arches and so on. But there is this system of passive supports. These passive supports would, for example, include some of these rather taut ligaments. And then the dynamic supports, when we talk about the dynamic supports, primarily talking about those intrinsic muscles and their reflex contraction as you are walking, running, jumping, or so on. Together, then, you get this very, very dynamic system. Having said that, I saw this study a couple of years ago. Apparently, about 1 in 13 of us have bendy chimp feet. Any of you want to fess up? I feel that I have a responsibility to point out anybody that's ambulating down the hallways with the bendy chimp feet. But the idea here is that instead of having this concavity, these individuals, the 1 in 13, are better suited to climbing, I guess is what the speculation is. And you can see this person has a bendy chimp foot. It bends right there in the arch region. All right. As I say, I want to sort of conclude some of this. What we're looking at here, does anybody even remember? Any of you ever heard of Tom, Dick, and Harry?
No,
Oh,
it's not
okay.
related.
You want to go back to the chimney?
Yes, actually, the slide 77, Dr. King, the one before.
Oh, I'm sorry.
The
I was
arches of the foot. Yes, on this slide, what is actually that you want us to pay attention
Oh,
to?
I just want you to understand that when we're talking about the arches of the foot and the idea that we were making the comparison to the blade type prosthesis, that springiness, that inherent springiness, which according to the research ensures that we have an advantage even over these blade-like prostheses. That springiness is made possible by two general types of mechanical system in the foot. The passive supports, which consist primarily of those ligaments we just talked about, the binding ligaments, especially the long and short and the spring ligaments. And then the dynamic, and by the dynamic supports, we're just talking about the reflex contraction of the intrinsic muscles of the foot, in particular the brevis muscles, is what they're talking about. And collectively, then, you're not thinking about it, even though these are skeletal muscles, these are reflexes. By the way, maybe you can tell me, When we talk about a somatic reflex, where is that mediated? Where is the information that makes the contraction of these flexors and the brevis muscles occur? Where does that signal, where does that motor signal originate?
Cerebellum.
Probably not. If it's a reflex, probably in the spinal cord. Yeah, this is a reflex. It's probably gonna, and so this is probably one of the few reflexes that remains. But in any case, getting back to Bartek's question, it's the contribution of each of these components then that gives us this great capacity to run. You know, if you think about what we can do that other animals cannot athletically, and this was celebrated, I think, is it New Jersey or Pennsylvania, just last month. What is it that humans can do that most other, because we're not very strong, we're not very big, we're not very powerful, but how did we make a living for so many? What are you going to do with that? You can't intimidate bears. What can you do though to survive? There you go. Yeah. And when I say celebrated, does anybody? William said distance running. We're very much adapted to running long distances. At least you folks are. Not me. Did you keep up with the race? Where's the annual? I think it's every 1 or 2 years up in the Northeast. It's between a man and a horse, and every few years the man wins. I forget it. Anybody ever said, I think the man is given a head start. But there used to be old Duffy readers and things that would have, you ever heard of C. Spot runs? That's what I do. That's how I learned to read. Spot was the dog, and Tom, Dick, and Harry was the family, and brothers or something. I forget. I don't read as much Duffy readers as I used to. But in any case, what we're looking at here, this was a mnemonic. This is something called the tarsal tunnel. And when I was complaining earlier about my problems with the elliptical machines, and my foot would go numb as I would stand on those things for a long period of time. There are a number of possibilities. I might ask you, I'm on the patient is on the elliptical machine, and within, I don't know, let's say 3 or 4 minutes, they begin to feel foot numbness. In general, what might you ascribe that numbness to? What might be the cause? Not so much the specific anatomy, but what might be the cause of that in a very general sense? Yeah. Exactly right. Or what else might cause it? Exactly right. So either way, and I'm not sure it's established whether
vascular.
I'm sorry, I should either nerve compression, impingement, or there could be compromised blood flow. If you look into it, I don't think in all cases it's very clear what the leading cause is. But in any case, we will talk about several. You've heard of carpal tunnel. We'll talk about carpal tunnel later. There's cubital tunnel syndrome we'll talk about. This is tarsal tunnel, and it too can be prone to problems with repetitive use and other issues. What you'll notice running through that, and this is what I want you to know anatomically, I'm not so concerned, this is not a pathology course. But in that tarsal tunnel, notice you have the tibial artery and vein, very important, tibial nerve, both flexor tendons, flexor hallucis and flexor digitorum longus. Remember, the longus is extrinsic. And also the tendon to the tibialis posterior muscle, which is of these structures probably the least important.
You said the flexor is extrinsic.
The flexor longus is flexor brevis is intrinsic.
How about the hallucis?
The flexor hallucis longus is also extrinsic. There's also a flexor hallucis brevis, and we have the little illustration of those flexor the brevis muscles in it. So often with the tarsal tunnel syndrome, you get the numbness, tingling, and pain, but again, there can be other causes for that too. I'm not sure in all cases I can necessarily attribute my elliptical problems to the tarsal tunnel. And you can see some of the structures here. Here's the tibialis posterior. Here's the flexor digitorum longus tendon there. And then to finish this section up, we've already indicated the blood supply to the foot is primarily by these two arteries, posteriorly, the posterior tibial artery, and anteriorly, the anterior tibial artery. Notice that the posterior tibial is going to give rise to the plantar arteries. We saw a system of those a moment ago. And then the anterior tibial, we also saw this earlier, gives rise to the dorsalis pedis. We indicated that the pulse could be detected there between the first and second metatarsals. So again, this is just an indication. Posterior tibial goes to the lateral and medial plantar arteries, and this is simply pointing out that you can palpate the artery against those underlying tarsal and metatarsal bones. There's the dorsalis pedis coming down here, anterior tibial dorsalis pedis. Here's the superficial arch. There's generally one a little deep, and it's distal to that as well. And then on the plantar side, you can see the posterior vessel branching into these plantar arteries on the underside of the foot, posterior tibial. The veins of the foot, the deep veins, have the same names as the arteries. We've already talked about the drainage from the great saphenous and the small saphenous. Remember these two veins. The great saphenous goes up to the groin. The small saphenous goes back to the popliteal region of the knee. And then with respect to the innervation, as we pointed out before, this is variable and kind of complicated. But I just want you to be aware of some of the terms we've talked about. So remember the tibial nerve, that tibial that runs down the posterior side of the leg there. It innervates all intrinsic muscles of the foot, except the extensor digitorum brevis. Everything else is all the other intrinsic muscles, such as the interosseous and the lumbricals, are going to be innervated by the tibial. The deep fibular or perineal is going to innervate the extensor digitorum brevis, the one that we just mentioned up here. The superficial fibular is going to give rise to the dorsal cutaneous nerve, and you can see the dorsal cutaneous nerves over here. And these would be the dorsal cutaneous nerves here. And then, with respect to the sural and the saphenous nerve, what I would have you pay attention to is this. So, in general, because of the anatomy, the anatomy of how this nerve arises, this is generally providing lateral cutaneous. The sural is providing lateral cutaneous innervation. The saphenous nerve, which remembers that long continuation of the femoral, is the medial side. And that's it for the lower limb. I think in light of the festivities today, we'll call it quits there. And so we'll pick up with the upper limb. Remember, Monday then, as I understand the schedule, and that's the schedule